Hi everybody, and welcome to our module on anticoagulant drugs. Thrombus disorders are disorders where a blood clot forms where it should not be and causes clinical symptoms. For example, in atrial fibrillation, a blood clot can form in the left atrial appendage. It can then break off and travel to the brain and cause a stroke. As you probably know, in myocardial infarction, blood clots form in the coronary arteries. In deep vein thromboses or pulmonary embolisms, there is formation of clots in the deep veins of the legs which can travel to the pulmonary artery. A stroke is a blood clot in the central nervous system circulation, and critical limb ischemia is a blood clot in the peripheral circulation, usually to the leg, causing a decrease in blood flow. So in all of these disorders, antithrombotic drugs are used for treatment. They're used acutely to try and eliminate a clot that is already formed, but where you will more often see them used is for prevention. So in patients who have a high risk of clot, they will often be advised to take an antithrombotic drug chronically. This may be someone who's had a clot before. Those patients are at high risk for a second clot. Or it may be someone who's never had a blood clot, but we just think they're at such high risk we are willing to place them on one of these drugs. The two ingredients of a thrombus are fibrin, which comes from the coagulation cascade, and activated platelets. They come together to form a blood clot. Drugs that block the formation of fibrin are called anticoagulants, and that's what we will discuss in this module. Drugs that block the activity of platelets are called antiplatelets, and I talk about those in a separate module. And then there's a final class of drugs called thrombolytics. These drugs are unique in that they break up fibrin clots that have already formed. Anticoagulants and antiplatelets do not break up clots that have already formed. They just prevent the formation of additional clot. They're helpful in thrombus disorders because they decrease the amount of thrombus being formed and they allow the body's natural anticoagulants to work. Thrombolytics are unique in that they directly break up clots, and we'll talk about those in this module as well. I've always found it helpful to think about the fact that the body tries to strike a natural balance between clotting and bleeding. If you have too much clotting, you will develop a myocardial infarction or a pulmonary embolism or a deep vein thrombosis or a stroke or any of the thrombus conditions I talked about a few slides ago. On the other hand, if you don't have enough clotting, you will develop GI bleeding or central nervous system bleeding or bruising. And the body is always trying to strike the right balance. We try to only administer antithrombotic drugs when we think the risk of one of these disease processes is very high, and we think that the risk to the patient of bleeding is lower than the risk from the disease. All of the anticoagulants we're going to discuss in this module affect the coagulation cascade in one manner or another. They generally don't affect platelets or the bleeding time. I talk about coagulation in detail in another module, but I'll just review a couple important points here. There are two ways to activate the coagulation cascade in the laboratory on a blood sample. The first way is to add tissue factor. That's called using the extrinsic pathway to form fibrin and a clot. The second way to test the coagulation cascade is to add a negatively charged substance like silica. This is called using the intrinsic pathway to form fibrin and a clot. When we add a negatively charged substance like silica to a sample and measure the amount of time it takes for a blood clot to form, that's called measuring the activated partial thromboplastin time, or the PTT. You add plasma from a patient to a negatively charged substance like silica, and the normal time to form a clot is about 30 seconds. If we add tissue factor to a blood sample and time how long it takes for a clot to form, that's called measuring the prothrombin time, or the PT. You add a plasma sample to tissue factor and the normal time to form a clot is about 10 seconds. Now the PT is often converted to something called the INR, or the International Normalized Ratio. To calculate an INR, you take the patient's PT and divide by a control PT, and normal INR is 1, and therapeutic on a drug like warfarin, for example, is about 2 to 3. A final way to test the coagulation cascade is to measure something called the thrombin time. This isn't really used much in the modern era outside of research. The thrombin time involves adding thrombin to a blood sample and measuring the time to form the clot. So this basically tests the very end of the coagulation cascade. The only way this test will be abnormal is if there's an inhibitor of thrombin present or if there's not enough fibrinogen around to form fibrin in a clot. So let's begin our discussion of specific anticoagulants by talking about heparin. Heparin is a polymer. It's a type of molecule called a glycosaminoglycan. Its structure is shown at the bottom of the screen. It's made up of repeating sugar units. It occurs naturally. You can find it in mast cells. And when you have a sample of heparin, you will find polymers of varying chain lengths. So for example, in a sample of heparin, some of the chains will be very long, some will be very short, and some will be in the middle. It's used clinically in two forms. The first form is called unfractionated heparin. When you administer this form of the drug, you are administering widely varying polymer chain lengths to the patient, and that has one set of effects which we'll talk about in a minute. The second way to administer heparin as a drug is to administer only the low molecular weight polymers. These are the smaller polymers only, and when you take out just the low molecular weight polymers, the drug has a different effect, and we'll talk about both of these in the next few slides. So first let's talk about unfractionated heparin, and one of the most important things to know about this drug is that it works through a natural anticoagulant called antithrombin 3. I talk about antithrombin 3 in the coagulation module, but what it does is it inactivates a number of different coagulation factors as I've shown in the picture here. So unfractionated heparin will activate antithrombin 3, and then antithrombin 3 will go and inactivate thrombin and factor 10A and all of these factors involved in the intrinsic pathway. Heparin is a liquid medication, so it's given intravenously or sub-Q. You won't see people taking heparin as a pill. It has an acute onset of action, and when you test the coagulation cascade in a patient taking unfractionated heparin, you will find that the PTT is prolonged. This is how we monitor the effects of heparin. If we go back to this slide, you can see that heparin affects numerous components of the intrinsic pathway. Therefore, it should make sense to you that the PTT will become prolonged. And an easy way to remember this is to just remember that heparin affects the intrinsic pathway, which is monitored by the PTT. Now, it will also increase the thrombin time. If we go back to this slide, unfractionated heparin inhibits thrombin, so therefore it should make sense to you that the thrombin time will be prolonged. And then finally, the PT can be affected, but usually at high dosages. Going back to this slide once again, when you add tissue factor to test the extrinsic pathway, you need factor 10A and thrombin, and they are both affected by heparin. So at higher dosages, you will see the extrinsic pathway become abnormal and the PT become prolonged. However, the intrinsic pathway is much more sensitive because so many factors are affected. Therefore, the intrinsic pathway and the PTT is the preferred test to monitor the effects of heparin. So that brings me to the final point about heparin, which is that it binds extensively to plasma proteins and inside of cells, and there's a highly variable response from one patient to another. So for this reason, the dose must be adjusted to reach the goal PTT. If you administer 5,000 units of heparin to two different patients, you may get two very different effects. You have to check the PTT to see if the patient has received enough medication or too much medication. There is a reversal agent for unfractionated heparin. It's called protamine. It also works to some degree with low molecular weight heparin, although it's not as effective. It binds heparin and neutralizes the drug, and it can be used if a patient is overdosed on heparin accidentally. One of its major places where it's used is in cardiac surgery. So when patients have open heart surgery, they have to immobilize the heart, and this means the patient needs to be placed on something called the heart-lung machine, which oxygenates the blood. Circulating blood through the heart-lung machine requires very high dosages of heparin to prevent clots from forming. When the case is over, you obviously want to quickly reverse the effects of heparin so that the patient doesn't bleed, and this is done by administering protamine. Places where you can often see unfractionated heparin in use include the acute management of a number of thrombotic disorders, for example, DVT or pulmonary emboli or myocardial infarction or stroke. In all of these conditions, unfractionated heparin is administered because it will quickly inhibit the coagulation cascade and allow the body's natural anticoagulants to begin breaking down the clots. It's also often used for prophylaxis against deep vein thrombosis in hospitalized patients. It can be given subcutaneously. Patients who are bedbound in the hospital often form DVTs. That's because there's stasis of blood because they're not moving. So by administering unfractionated heparin as prophylaxis, you can lower the risk of DVT. The main side effect of this drug is bleeding. Rarely patients can develop thrombocytopenia. We'll talk about that in a minute. If patients take this drug for long-term use, which is not often done in the modern era, they can develop osteoporosis. It increases bone breakdown. And then finally, sometimes patients on unfractionated heparin have a very mild increase in their AST or ALT. This is usually not clinically significant. Now let's talk about thrombocytopenia, which can be a dangerous and life-threatening adverse effect of heparin. Many patients who receive heparin therapy have a mild 10 to 20% drop in their platelets. This is called non-immune thrombocytopenia because it's not immune-mediated. It's the result of a direct suppressive effect on platelet production. So a normal platelet count is about 300 to 400,000. So in a patient on heparin, you may see this fall to maybe 290,000. But this is a mild drop. The platelet count remains well within the normal range. And that is an example of non-immune thrombocytopenia in a patient on heparin. A much more serious condition is called heparin-induced thrombocytopenia, or HIT. This is an immune-mediated reaction where immune complexes bind to platelet factor 4 and heparin and elicit an immune response. This is an example of a type 2 hypersensitivity reaction. To understand the pathophysiology of heparin-induced thrombocytopenia, you have to recall that platelets make a substance called platelet factor 4, which is stored in their granules. When platelets become activated, platelet factor 4 is released and it can bind to heparin. In a small number of patients, IgG antibodies will form to the heparin platelet factor 4 complexes. In turn, this will create larger complexes of IgG bound to heparin bound to platelet factor 4. These complexes can bind to platelet surfaces, and then platelets will be removed by splenic macrophages, and that can lead to thrombocytopenia. Now, if this were the whole problem, it might not be so bad, but what's more dangerous about heparin-induced thrombocytopenia is that these complexes which bind to platelet surfaces can sometimes activate platelets. This can lead to platelet aggregation and activation, which can cause thrombosis. So you're administering a blood thinner, heparin, but you are getting, by accident, the effect of thrombosis, the opposite of what you want to achieve. In addition, the platelet aggregation and activation can lead to more platelet factor IV release. That leads to more binding to heparin and makes the whole problem worse. So heparin-induced thrombocytopenia occurs 5 to 10 days after exposure to heparin. That's because it takes a few days for those antibodies to form. There's an abrupt and significant fall in platelets, usually greater than 50%, so a much greater fall in the platelet count than in the non-immune thrombocytopenia we talked about before. And then the serious and life-threatening part of heparin-induced thrombocytopenia is the formation of arterial and venous thromboses. So these patients can develop DVTs, they can get ischemic limbs and have blue toes. If you see a patient on heparin who develops a blood clot disorder, you should think of heparin-induced thrombocytopenia. Luckily, this is rare. It only occurs in a few percent of heparin patients. And patients who develop this complication must be treated with alternative drugs. It's not enough to just stop the heparin because these patients are hypercoagulable. You have to stop the heparin and then start another drug, usually a direct thrombin inhibitor like leparudin or bivalirudin. You make a presumptive diagnosis of HIT in a patient who has a significant drop in platelet count while they're receiving heparin therapy, or a patient who forms a thrombus while on heparin therapy. And once you suspect the diagnosis, you need to stop heparin immediately. The definitive diagnosis is done by HIT antibody testing. These are antibodies that you can detect in the plasma to platelet factor IV complexed with heparin. This testing takes a few days to come back. You don't want to wait for that. If you think a patient might have HIT, you stop the drug and start alternative therapy. Now let's talk about low molecular weight heparin, which is also called enoxaparin. Remember I told you before that unfractionated heparin works through antithrombin 3 and inactivates all of these factors in the coagulation cascade. Well, low molecular weight heparin also works through antithrombin 3, but by using only the low molecular weight polymers of heparin, the effect is limited to factor 10A. So low molecular weight heparin will only inhibit factor 10A. So you might be thinking, what's the advantage of using low molecular weight heparin over unfractionated heparin? And the advantage is that the dose is based on weight. There's no titrating to the PTT. Low molecular weight heparin has a very predictable effect, and that's because there's reduced binding to plasma proteins in cells. So you can administer it sub-Q, and once you've administered it, you can know it's working without needing to monitor the PTT and adjust the dose. Another advantage is that it has a lower incidence of HIT, although it still can cause, and this is not an acceptable alternative to use in a patient who develops HIT on unfractionated heparin. If you do test the coagulation cascade in people taking low molecular weight heparin, you will find that the thrombin time is not affected. That's because unlike unfractionated heparin, low molecular weight heparin does not inhibit thrombin. You will also find that the PTT is not very sensitive to changes in dose on patients taking low molecular weight heparin. To understand that, let's take a look at this chart. So if you were to plot the plasma concentration of a drug versus the PTT, these are the two curves you would generate for unfractionated heparin and low molecular weight heparin. Unfractionated heparin has a very steep curve. This makes the PTT very useful for monitoring because as the concentration moves just a little bit left or right, the PTT changes a lot. For low molecular weight heparin, the curve is very flat. You can change the concentration of the drug significantly and the PTT will barely move. And this is why the PTT is not useful for monitoring the effects of low molecular weight heparin. It will increase, but it's not sensitive to changes in plasma concentration. And once again, that's because unlike unfractionated heparin, low molecular weight heparin only affects factor 10. It does not affect all those other components of the intrinsic pathway that lead to changes in the PTT. There are some special circumstances where we do want to monitor the effects of enoxaparin on the coagulation cascade, and in these situations, we use a special blood test that is only used for enoxaparin, and that's called an anti-10A level. The reason we use this special test is because, like I showed you on the last slide, enoxaparin has a limited and insensitive effect on the PTT. Usually a standard dose is used based on weight with no monitoring, but the two exceptions where we sometimes use this anti-10A level is in patients who are obese or patients with renal failure. In these two situations, there can be an unpredictable effect of low molecular weight heparin, and for that reason, an anti-10A level is sometimes monitored. The way you check an anti-10A level is by taking a blood sample from a patient on enoxaparin and adding it to a special 10A substrate that is linked to something called a chromophore, which will illuminate when the 10A substrate is split. If there is very low 10A activity, there will be a small amount of splitting of the substrate, and there will only be a little bit of illumination from the chromophore. On the other hand, if there's lots of 10A activity, you will get lots of splitting of the 10A substrate, and the chromophore will illuminate more, and you can detect this in the laboratory and you can convert it to a number called an anti-10A level. Our next class of anticoagulants is the factor Xa inhibitors. So you should know that unfractionated heparin and low molecular weight heparin are sometimes called indirect factor Xa inhibitors. That's because they do inhibit factor Xa, but they work through antithrombin 3. The direct factor Xa inhibitors are rivaroxaban and apixaban, and they directly inhibit Xa. Xa is an enzyme that converts prothrombin to thrombin, and these drugs are basically enzyme inhibitors. So rivaroxaban and apixaban are the two factor Xa inhibitors, and you will mainly see them used in atrial fibrillation as alternatives to warfarin. As we'll see later in this module, patients on warfarin need regular monitoring of their PT-INR level. That is not necessary if patients take these drugs instead. They are administered via standard dosing. Now, if you do test the coagulation cascade in patients taking a 10A inhibitor drug, you will see that these drugs can increase the PT and PTT. That's because 10A is involved in both pathways. You won't see any effect on the thrombin time, and that's because these drugs do not inhibit thrombin. The next class of drugs are the direct thrombin inhibitors. These are enzyme inhibitors of the enzyme thrombin. Most of them are intravenous or subcutaneous drugs. The one exception is dabigatran, which is an oral drug. The direct thrombin inhibitors can prolong the PT, the PTT, and the thrombin time, and that's because thrombin activity is common to all three of these tests, and these drugs inhibit thrombin. And I told you before that the thrombin time isn't really used in the modern era clinically, but one thing that you should keep in mind for your boards regarding the drugs is that only unfractionated heparin and the direct thrombin inhibitors will prolong the thrombin time. The only thing from a drug point of view that's going to prolong the thrombin time is something that inhibits thrombin function. Unfractionated heparin does this indirectly through antithrombin 3, and the direct thrombin inhibitors do this as a direct drug effect. One of the places you'll see the direct thrombin inhibitors are in patients who have heparin-induced thrombocytopenia. I mentioned this before, but all of these direct thrombin inhibitors can be used in patients with HIT. Like I told you before, when a patient develops HIT, you need to stop the heparin and start one of these drugs, and the PTT is often monitored while these drugs are being administered, similar to the way it's monitored in unfractionated heparin therapy. Some of these drugs are used in acute coronary syndromes or coronary interventions like coronary stenting. Bivalirudin is sometimes used in this situation. And then finally, in atrial fibrillation, dabigatran is an alternative to warfarin. It's an oral direct thrombin inhibitor, and it requires standard dosing. You don't need to monitor the PT-INR, so it's another alternative to warfarin. So now let's talk about warfarin, which is a very commonly used anticoagulant. It's an antagonist to vitamin K. And recall that there are 4 coagulation factors that depend on vitamin K. They're called the vitamin K factors, and they are factors 2, 7, 9, and 10. And you will see the levels of these factors fall when patients take warfarin. In order to understand how warfarin works, we have to review the role of vitamin K in the synthesis of clotting factors. So what vitamin K does in the synthesis of clotting factors is form something called gamma-carboxyglutamate residues on the clotting factors. So let's talk about what that means. So if you look at the precursor to a clotting factor, you will find residues of glutamate. Glutamate is an amino acid, and it's incorporated into the precursors. So the carbon next to the nitrogen in glutamate is called the alpha carbon. The next carbon is called the beta carbon, and the third one is called the gamma carbon. What vitamin K does is contribute to the carboxylation of this gamma carbon. This means the addition of a carboxylic acid group to the gamma carbon. And vitamin K allows this to happen, and that creates gamma-carboxyglutamate residues in the clotting factors, and this leads to the formation of activated clotting factors. There are 2 forms of vitamin K. One form is called the K1 form. It's found in green leafy vegetables, things like cabbage and kale and spinach. You can also find it in egg yolk and in liver. The second form comes from bacteria. The bacteria in your gastrointestinal tract synthesize this, and you get a lot of vitamin K from that source. Warfarin works by inhibiting an enzyme called epoxide reductase. So what epoxide reductase does is it converts vitamin K to a reduced form. When vitamin K assists in the gamma carboxylation of a clotting factor, it becomes oxidized. Epoxide reductase reduces it back to the reduced form of vitamin K and allows it to continue to contribute to the activation of clotting factors. By inhibiting this enzyme, all of the vitamin K gets tied up in the oxidized form, and it's not able to make more activated clotting factors. Warfarin takes several days to achieve its effects. This is because the drug doesn't do anything to the clotting factors that are already present. What it does is inhibit the production of new clotting factors. This means you have to wait for the already activated clotting factors to have their levels fall, and then warfarin will blunt the production of new clotting factors. Another thing you need to know about warfarin is that the dose has to be monitored and adjusted to reach the target PT-INR. This is because the effect of warfarin is heavily dependent on the amount of vitamin K in the body. So for example, the drug's effect will vary with the amount of vitamin K in the diet. If you consume more vitamin K, there will be a different effect on warfarin than if you consumed less vitamin K. Additionally, many patients taking warfarin are exposed to antibiotics and they can decrease the GI bacteria. That means less production of vitamin K from the GI bacteria, and this can raise the INR if you aren't carefully monitoring the effect of the drug. And then finally, there are many drugs which interfere with the metabolism of warfarin, so for all of these reasons, you have to constantly check the PT-INR, usually at least once a month, and adjust the dose accordingly. Now let's talk about why the PT and the INR is the preferred test for monitoring the effects of warfarin. On the screen, I've circled the 4 vitamin K-dependent coagulation factors, and you can see that some of them are part of the extrinsic pathway and some are part of the intrinsic pathway. So that begs the question, why do we choose the PT, the test of the extrinsic pathway, to monitor warfarin? Well, the reason is because factor 7, shown right here, which is part of the extrinsic pathway, has the shortest half-life of all the vitamin K-dependent factors. This means that factor 7 will be the first level to fall after a patient begins taking warfarin. Therefore, the extrinsic pathway in the PT test is much more sensitive to the effects of warfarin. So I've summarized these points on this slide here. Factor 7 has the shortest half-life of the vitamin K-dependent factors. For this reason, it is the first level to fall after warfarin administration. If you look at this table on the screen, factor 7 has a half-life of 4 to 6 hours. Contrast that with prothrombin, factor 2, which has a half-life of 60 to 72 hours. Only the PT test of the extrinsic pathway captures factor 7 activity, and that's why that's the preferred test in patients on warfarin. The PTT can become elevated in patients on warfarin, but it is much less sensitive, and the thrombin time will be normal because warfarin does not affect thrombin activity. Now, warfarin is an anticoagulant, but you should be aware that it has prothrombotic effects when you initiate therapy, and that is because of the effects of warfarin on protein C. Protein C is an anti-clotting factor which has a very short half-life, and it is also vitamin K dependent. Let's look at the bottom of the screen on our table again. I told you that factor 7 has a short half-life of 4 to 6 hours, but protein C also has a short half-life of just about 8 to 10 hours. What this means is when you initiate warfarin therapy, the protein C level can fall, and when the protein C level falls, this is prothrombotic, and it briefly creates a prothrombotic state. Eventually, the other factors have their levels fall, and warfarin's effect overall is antithrombotic. This effect is limited to the first few days of therapy. So a question that will come up on your clinical rotations is, should you use another drug like heparin anytime you start warfarin therapy? In other words, should you use an IV immediate-acting drug like heparin to anticoagulate the patient during that initial prothrombotic period on warfarin? The answer is yes, but this is usually not an issue in the hospital, and the reason is because for clot disorders like deep vein thrombosis and pulmonary embolism, heparin is used anyway because of its acute onset. You wouldn't want to start warfarin and wait 5 days for it to become effective in a patient who has a blood clot in their leg or in their lungs. So you start heparin because of its immediate effect, and this provides anticoagulation during initial warfarin therapy. The one exception is patients with atrial fibrillation. When a patient initially develops AFib, they don't have an active clot, they just have a risk of forming a clot. In this scenario, you will sometimes see warfarin started without heparin. The brief increase in the risk of clot during the first few days is very low, and it's often tolerated. Warfarin crosses the placenta, and it's avoided in pregnancy. There is something called the fetal warfarin syndrome, where babies have abnormal development if their mother is taking warfarin. For this reason, it's generally not used, especially in the first trimester. Unfractionated heparin is the drug that's often used in pregnancy because it does not cross the placenta. The main side effect of warfarin is bleeding. It's a big problem in people taking this drug chronically. The one other side effect you should know about is skin necrosis. So warfarin skin necrosis is a rare complication of therapy, and it mostly only happens in patients who are protein C deficient. You can also see it if you use very high dosages, which aren't used much anymore, but they used to be used years ago. So as I told you before, when you are initially exposed to warfarin, your protein C level falls. If a patient has an unknown protein C deficiency, this level will get very, very low, and they will become prothrombotic. And what they will develop is thrombosis of their skin tissue. This presents as large, dark, purple skin lesions in a patient a few days after starting warfarin therapy. When you see this in a board question, this is very rare in real life, but when you see it in a board question, you should think of protein C deficiency. Warfarin is often used for stroke prevention in patients with atrial fibrillation. It's also often used in patients with mechanical heart valves. A thrombus can form on mechanical heart valves and cause a stroke, so warfarin is administered to decrease the chance of this. And then finally, patients who have a deep vein thrombosis or a pulmonary embolism are often treated with warfarin for at least several months. Let me make a general point about chronic oral anticoagulation. So there are several indications for patients taking a pill every day for anticoagulation. One is atrial fibrillation, another is mechanical heart valves, another is prior deep vein thrombosis or pulmonary embolism. The prior standard therapy was warfarin, and for many years this was the only available therapy. It's an oral drug, its cost was low, but it always had one big downside, which is that it requires regular INR checks, which involve a monthly blood draw. This is inconvenient for the patient, and in addition, the levels frequently go up or down, so patients are often overdosed or underdosed. But there are now a number of alternatives to warfarin for patients who require an oral drug for chronic anticoagulation, and these drugs are called novel oral anticoagulants, or NOACs. There are two of these that work by inhibiting factor Xa. They are called rivaroxaban and apixaban, and there's one NOAC that works by directly inhibiting thrombin. This is called dabigatran. When these drugs first came on the market, there were no reversal agents to reverse the anticoagulant effects in patients who had life-threatening bleeding. That has now changed, and there is a reversal agent for the factor Xa inhibitors. It's called andexanet alpha, and it's an inactive decoy of factor Xa that binds the drug and prevents it from having an anticoagulant effect on actual Xa in the plasma. For dabigatran, the reversal agent is an antibody called idarosizumab. It's an anti-dabigatran monoclonal antibody that binds the drug and limits its anticoagulant effects. The major upside to NOACs compared with warfarin are that NOACs have consistent dosing, so you don't need to check the INR level on the patient. Some of the downsides are that these drugs can be expensive, especially compared to warfarin, which is very low cost, and NOACs can't be used in all patients. In particular, many of these drugs cannot be used in patients on dialysis or in patients who have mechanical heart valves. The last class of drugs I want to mention are the thrombolytics. There are three drugs in this class. One's called tissue plasminogen activator, the other is streptokinase, and the other is urokinase. I talk about all these drugs in the module on coagulation. They are naturally occurring substances which convert plasminogen into plasma. They can be administered as drugs to generate large amounts of plasmin, which will break down fibrin clots into fibrin degradation products and D-dimers. These are powerful clot buster drugs. They're used in acute myocardial infarction and stroke to break up the clots in either the coronary arteries or the central nervous system. The biggest downside of these drugs is that they carry a major risk of bleeding. In addition to breaking down fibrin, plasmin can break down numerous clotting factors, and there's a significant risk of bleeding, and therefore these drugs are only administered in certain special situations when the risk of bleeding is believed to be low. The last topic I want to mention in this module is the reversal of anticoagulant drugs, especially warfarin. So fresh frozen plasma can be used to reverse the effects of warfarin very quickly. FFP is plasma after removal of the cells, like red cells, white cells, and platelets. It's then frozen for storage, as the name implies. Once you thaw it, you have to use it within 24 hours or the clotting factors degrade, and it will correct deficiencies of any clotting factor. So all those vitamin K clotting factors whose levels are low in patients on warfarin will be corrected by FFP, and the PT and PTT will normalize after infusion. Vitamin K can also be given to reverse the effects of warfarin. This is done when the INR gets too high in the absence of serious bleeding. So the target INR for most patients on warfarin is 2 to 3. Remember that 1 is a normal INR, so 2 to 3 usually means they're therapeutic on warfarin. So if the level gets much higher than 3, then vitamin K is sometimes given to reverse the effects of warfarin. Vitamin K can be given orally or IV, although rarely do you use the IV form, and that's because it can cause anaphylaxis. So for example, if the INR gets high, such as 3 to 5, most people will just hold the warfarin. If the INR is higher than that, like 5 to 9, many people will hold the warfarin and also give a dose of oral vitamin K to bring down the INR. If the INR gets dangerously high, like greater than 9, this is when IV vitamin K is sometimes administered, or people sometimes use FFP. And keep in mind that all these suggestions I've written here on the screen are only for when there's an absence of serious bleeding. If the patient has a severe bleeding and any increase in the INR, sometimes even a normal INR like 2 to 3, that's when you administer FFP to quickly reverse the effects of warfarin so that the severe bleeding does not get worse. And that concludes our module on anticoagulants.